Good morning. Good evening. Hi, how are you guys doing? So, today is our live session. Today, we are going to talk about the important images in general surgery. So, can I hear from you guys, whoever is online? How are you guys doing? I have arranged today's lesson or in a form of an MCQ. So, I want you guys to participate, okay? So, can I just hear from you guys, whoever is here? Right? So, let us start by talking about things. Right. So we'll be starting our today's session, and I'm just waiting for a couple of you to join us so that we can have a quick discussion on the important MCQs which we are having. Okay. So to begin with, this is our first MCQ. So what is the provisional diagnosis of the patient? Okay. So can anybody answer to this particular question? What is the provisional diagnosis of this patient? Yes. What is the answer? Is it A, B, C, or D? Is it multinodular goiter, retrosternal goiter, thoracic outlet syndrome, or superior vena cava syndrome? Okay, so Jyoti is saying that it is superior vena cava syndrome. So Jyoti, why are you saying it as a superior vena cava syndrome? Well, actually the answer is wrong. This answer to this particular question is multinodular goiter. Sorry, I'm really sorry. It's a retrosternal goiter. Okay, so what is being shown in this particular image is a Pemberton sign. So what is it? It is a Pemberton sign. Now, in this recent times, we got few questions on the clinical tests for the thyroid. Okay, so that's why I included this particular question. But thank you so much for answering. It's okay. It's comparative. It's okay. It's okay to commit a mistake over here, but you shouldn't commit it in the final exam. So it's good that you attempted. Right. So what is the answer to this particular question? The answer is this is a retrosternal goiter. So what is being shown in this? It is a Right, it's a retrosternal goiter. So it is a Pemberton sign. So what exactly is a Pemberton sign? In this, what happens? The patient, when he's sitting in front of you, he's absolutely normal. But if at all you ask the patient to raise his both arms above his ears, what happens? There occurs a facial plethora. So I hope you can appreciate this. There is a facial plethora. What do you understand by plethora? That is, the vessels, like there is a vessel distension and the blood is not allowed to go from face towards the heart. Why is this happening? Because in the region of a thoracic inlet, what is there? There is a goiter. So there is a retrosternal goiter, and if you decrease the space further, the vessels will get compressed and the proper drainage of the vessels will not take place. Okay, yeah, engorged blood vessel. Very good, Danish. So good to have you, Danish. Right, so let's move on to the next question. Okay, so this is a Pemberton sign which you see in the retrosternal goiter. Now, moving on to the next question. So, what is the shelf life of this intravenous supplement? So, what is being shown in this image? We have a human albumin. Okay, so I hope you can appreciate this. This is a human albumin. So, in other words, I'm trying to ask you, what is the shelf life of this human albumin? Okay, so what is the shelf life of this human albumin? Is it 5 days, 2 months, 2 years, or 6 months? So Danish, Jyoti, I want the answer from you guys. Can you please tell what's the answer? Anything which comes to your mind. So what do you think should be the answer to this particular question? Okay, well, see, understand, the answer to this particular question is 2 years. Okay, no, it's 2 years, Danish. Okay, it's not 6 months, it's 2 years. So what happens? This particular thing, like human albumin, this can be stored for 2 years. And can you tell me at what temperature do you store this human albumin? So we store this human albumin at the room temperature. So these points are important. Okay, so we can store the human albumin at room temperature for a period of 2 years. Okay, so this is important. Okay, what else can be stored at the room temperature? Can you tell me what else can be stored at the room temperature? It is platelets. Okay, so what can we store at room temperature? We can store platelets at room temperature. And for how many days can we store the platelets? So platelets can be stored for 5 days. Okay, so for 5 days Right. So platelets, very good, Danish. So answer is platelets. But yes, for how many days can we store it? So we can store it for around 5 days. Okay. So this is about the human albumin. Okay. Right. Now let us talk about the next MCQ. What is the indication of this device? Okay, so this is something which you might not have seen, or it's very simple, not that great big deal. Okay, so what is the answer to this particular question? So what is an indication of this device? So before going to the MCQ, can you tell me what is the diagnosis, like what is this device? So Jyoti, I want you also to participate, and any other person who is online, I want you guys to participate. Okay, so what is the answer to this particular question? So what is this? What is shown in this particular image? What you see here? So this is a IVC filter. Very good. So this is a IVC filter. So it is basically a greenfields IVT filter. Okay, right. So what is an indication of this device? Is it poor compliance of the medications on the patient side? Contraindication to give any anticoagulant, recurrent thromboembolism despite adequate anticoagulation therapy, or all of the above? So what do you think? A, B, C, or D? What is the answer? Okay, well, the answer to this particular question is in fact D, all of the above. Okay, so this is important. Let us have a look at the main indications of doing this. Okay, so let us have a look at the main indications of putting up a IVC filter. So you will not put up a IVC filter in every patient. Okay, so what is the main indications of putting up a IVC filter? If there is a failure of anticoagulation, okay, with recurrent venous thromboembolism despite anticoagulation therapy. So this is one of the very important indications. So you have given the patient anticoagulant therapy, you have sent the patient home on warfarin, but still the patient is coming to you with a venous thromboembolism. Okay, so this is the primary and the main indication of putting up a IVC filter. Then what is the what else? If there is a contraindication, so that the patient cannot take the anticoagulation. Okay, so what can be the contraindication? Let's say the patient is at a high risk of bleeding, okay, or if there is a real bleeding which is occurring, let's say the patient has thrombocytopenia, or maybe the patient has some large CNS tumor or something. So any contraindication so that we cannot give the patient anticoagulation therapy, this is again an indication to put up a IVC filter. What else? Let's say, this is important, this has been asked, large free floating iliocaval thrombus. Okay, so large free floating iliocaval thrombus, yes, this is again an indication. Limited cardiopulmonary reserve, let's say the patient is suffering from col pulmonale. So even a small amount of thromboembolism, if it occurs, the patient will land up into right side heart failure. Poor compliance of medications on the patient side, and patient is at a risk of fall while anticoagulation therapy. Let's say if the patient is 85-year-old with Parkinson's. Okay, and if you put the patient on anticoagulation therapy, patient is going to the bathroom, he just fell down and he will develop a massive intracranial bleed and he might die. So these are the relative indications, but the two absolute and the most critical indications are failure of anticoagulation therapy. That means patient is on anticoagulation therapy, still the patient is coming to you with a recurrent venous thromboembolism despite anticoagulation. Other is contraindication or severe complication to the anticoagulation therapy. And these are the relative indications we just saw, right? Now let us have a look at this particular figure. So what is the stage of the burns which has been shown in this particular figure? So what is the stage of the burns which has been shown? I can see a couple of you have also joined us. So it is really good to have you guys. Welcome to the class. And we are on our fourth question. So can you please contribute? What is the stage of the burns which is shown on the image? So what is the stage of the burns? Okay, so Danish is up with the answer, Monali is with the answer. So yes, it is a second degree burns. Okay, so it is basically a second degree superficial burns. Okay, so this is a very simple question. I just wanted to revise with you the stages of burns. That is why I put this question. So what are the stages of burns? Okay, so first degree burns, it means that there is just a simple erythema and no other problem is there, and patients will usually heal on itself without any treatment needed. In the second degree burn, we have a superficial second degree burns, and then we have a deep second degree burns. In the superficial second degree burns, the characteristic thing which is occurring is this bulle. Okay, so we see this bulle. So this is a characteristic thing which is occurring in this particular patient. What about the deep second degree burns? In the deep second degree burns, the characteristic thing which is present is loss of decreased sensations. Okay, so decreased sensation, but at the same time, what is present? We preserve the pin prick sensation. So in the question, what will be given to you? That pin prick sensation is preserved. Okay, so pinprick sensation is preserved. So this is something which you will look for in the MCQ. So if the patient has a bulle, it is superficial second degree. If the patient has decreased in sensation but the pinprick sensation is preserved, it is deep second degree burns. What about the third degree burns? In this, the characteristic finding is scar formation. Okay, so scar formation is a characteristic finding of third degree burns, and in the fourth degree burn there is a exposure to the underlying bones and the muscles. Okay, so let us move on to the next question. What is the flow rate of this cannula? Okay, so can you tell me what is the flow rate of this cannula? It is a green cannula, IV cannula. Okay, so first can you tell me what is the gauge of this cannula? Is it a 16, 18, 20 or 22 gauge cannula? So it is a 18 gauge cannula. Okay, so yes, it is a 18 gauge cannula. Can you tell me what is the flow rate of this? Is it A, B, C or D? Okay, very good. So Danish has answered it as C. Yes, that is the correct answer. It is 90 ml per minute. Okay, and what about gray cannula? It is 180. So gray cannula, the flow rate is 180 ml per minute. 90 ml per minute is for the green. 60 is for the pink one. Okay, so yes, answer to this particular question is in fact 90 ml per minute. Now, another thing which I want you to know is this IV cannula. This is the most common cause of thrombophlebitis. Okay, so this is the most common cause of thrombophlebitis. Okay, so please remember this. IV cannula insertion, if somebody asks you which is the most common cause of thrombophlebitis, it is IV cannula insertion. And Danish, you have answered it as 16. Well, why? Okay, gray is 16 gauge and the green is 18 gauge. Okay, I think you have answered it that way only. But yes, don't get confused. Green is 18 gauge cannula and the gray cannula is the 16 gauge. Okay, and yeah, this is another MCQ, which is the most common cause of thrombophlebitis. It is IV cannula insertion. Okay, yes, right. Now let us move on to the next question. Okay, so what is the diagnosis of this patient? Okay, so is it diverticulosis, polyposis, visceral perforation or Hirschsprung disease? So what is the answer to this particular question? So yes, Jyoti, it is 618. Very good. So can you please answer this particular question? Is it A, B, C or D? What is the diagnosis which has been shown in this particular patient? So Manali is answering it as A. So diverticulosis. Do others agree? So Danish, no, it is not the Hirschsprung disease. It is in fact a diverticulosis. Okay. So yes, Manali, you are right. It is a diverticulosis. Why it is a diverticulosis? Okay. So can you see this kind of thing? So this is basically this typical sawtooth appearance. So what is it? What is being shown in this figure? It is a sawtooth appearance. Okay, so this is a sawtooth appearance which has been shown in this particular figure. Right, now if I ask you what is the investigation of choice for diverticulosis? What is the investigation of choice for diverticulosis? No, this is not an accordion sign. This is a sawtooth appearance. Okay, right. So if I ask you what is the investigation of choice for diverticulosis, it is in fact barium enema. Okay, it is barium enema. Okay, and if I ask you what is the investigation of choice for diverticulitis? Okay, so what is the investigation of choice for diverticulitis? Can anybody answer? It's a very important question. Investigation of choice for diverticulitis. Can you answer, guys? So good to have you, Ajmal and Shrikar. Right. So what is the answer to this particular question? Please answer, guys. USG? No. Manali? No. What is the investigation of choice? It is CT scan. Okay. So it is CT scan. Very good. Very good. Very good. CT scan. Okay. So please remember this. So diverticulosis is different. Diverticulitis is different. In the diverticulosis, investigation of choice is in fact barium enema. But in diverticulitis, it is contrast enhanced CT scan. Okay. So please have a note of these points. Okay. Now let us move on to the next image for today. What is the diagnosis which has been shown in this particular patient? So what is the diagnosis? Is it a traction diverticular of the upper esophagus, pulsion diverticular of the upper esophagus, traction diverticular of the middle esophagus, or a pulsion diverticular of the middle esophagus? Okay, so what is the answer? A bit kind of tricky or maybe a dicey question. What is the answer? Is it A, B, C or D? So Shrikar, what is the answer, guys? Manali, Shrikar, Danish, Jyoti, what is the answer? Right. So Danish is saying it's D, Ekta is saying it is C. Okay, anybody else has any opinion on this? Okay, well, yes, Ekta, you are absolutely correct. The answer is in fact C. Okay, so it is a traction diverticle of the middle esophagus. Okay, now I understand there are no true, nothing has been given to call it as a traction diverticula. But yes, see, understand what happens. Every middle esophageal diverticula is in fact a traction diverticula. By the image, you can appreciate that it is a middle esophageal diverticula. Yes. So guys, please don't get confused. It is not a pulsion diverticula. It is a traction diverticula. I understand it is not given anywhere, but understand in the esophagus, what do we have? We can have diverticula in the upper esophagus. We can have diverticula in the middle esophagus, or we can have diverticula in the lower part of the esophagus. Okay. So out of these, the upper mid esophageal diverticula and the lower esophageal diverticula, these are the false diverticula. Okay, so upper esophageal diverticula, what is the name of that? Can you tell me the name of the upper esophageal diverticula? Zenker's diverticula. Okay, it is a very, very important topic. In the lower esophageal diverticula, what is the name? It is a epiphrenic diverticula. So these two are the false diverticula. But the middle esophageal diverticula, these are usually the true diverticula. Okay, and why are they formed? They are basically the traction diverticula. Why it is formed? Let's say if there is a patient has a hilar adenopathy or due to some infection or something. So what will happen? When because of this hilar adenopathy, the lymph nodes will be enlarged, and what will be present around the lymph node? There will be lymphadenitis. So what will happen? These lymphadenitis will get attached to the kind of esophagus, okay, because they are in close vicinity of that, and when the infection will heal, it will get undergo some kind of fibrosis, and because of fibrosis, what will happen? It will pull the esophagus along with it, and that is why the middle esophageal diverticula are the true diverticula, and that is why they are also called as a traction diverticula. Okay, so please remember this. Upper esophageal diverticula and the lower esophageal diverticula are the false diverticula or the pulsion diverticulas, and the middle esophageal diverticula are the true diverticula or the traction diverticula. So this is an image of a middle esophageal diverticula, which is a traction diverticula. Okay guys, now let us move on to the next question. A pretty simple question for you guys. Okay, so what is the diagnosis which has been shown in this particular patient? Okay, I hope the image is visible properly. What is the diagnosis which has been shown in this particular patient? Is it a contusion, EDH, SDH, or SAH? Okay, so please be fast guys. What is the answer to this particular question? Right, so Danish is up with the answer. He's saying it is cerebral contusion. Anybody else? Yeah, okay, so yes, he's absolutely correct. This is a cerebral contusion. Okay, so a simple image, but yes, you should be able to appreciate. So what is a contusion? It is a basically a localized injury occurring to the brain parenchyma where there is extravasation of blood. At the same time, there is edema. So here there is a patient is having the brain edema, along with this patient is having some extravasation of blood. So this is basically a patient having a cerebral contusion. Okay, now again a very simple image for you. Can you, okay, no Ekta, it is not B, it is in fact A. It is a cerebral contusion. It is not a EDH. Okay, okay, did you answer for this particular question? What is the answer to this particular question? What is shown in this particular image? What has been shown? Yes, it is EDH. Okay, this is in fact EDH. Now this is a very simple image, but I just uh, wanted to so that this image goes in front of your eyes. So yes, obviously it is an EDH. What kind of what is the sign which you get in this? You get a lens-shaped opacity, which is also called as a biconvex. Okay, it is a biconvex or a lens-shaped opacity. Some people like to call it as an lemon-shaped opacity. Okay, so lemon-shaped opacity. So all these names are given for EDH. EDH is biconvex, lens-shaped, or a lemon-shaped opacity. Now, again, a very simple image for you. What is the diagnosis of this particular patient after a head trauma? So this is a patient who is suffering from. So Ikta, Danish, Shraddha, what is the answer? Ajmal? Okay, so answer to this particular question is in fact right, SDH. Okay, very good, SDH. Why? Because what are you seeing in this? You are seeing a crescent shaped opacity, that is a right, crescent shaped opacity, or you can call it as a concavo convex opacity, and some people like to call it as a banana shaped opacity. Okay, so that is why this is a subdural hemorrhage. Good guys, right? Okay, now let us talk about, okay, just a minute guys. Just a minute. Just give me 1 minute. Right. Right. So let us move on. Okay. So a tensile strength of this suture is. So what is the suture which has been shown here? This is a vicryl suture. So what I'm trying to ask you is what is the tensile strength of the suture? Now this is an important MCQ and you need to understand one particular concept in this. Okay. So just answer, then I'll try to talk about it. Okay. So what is the tensile strength of the suture? Is it 3 to 4 months, 3 to 4 weeks, 3 to 4 days, or non-absorbable suture? So what is the answer, guys? I'm waiting for you. I want you to answer. Okay. So just answer, then I'll talk about it. Okay, guys. Jyoti, Danish, Manali, Shraddha, Danish. Please answer. What is the answer to this particular question? So Danish is saying B, B. Well, guys, yes, you guys are correct. The answer is in fact 3 to 4 weeks. Now, how much time does it take to completely absorb the vicryl suture? Okay, so do you guys understand there is a difference between absorption time and there is a difference between tensile strength? Okay, so there is a difference between absorption time and tensile strength. Now what is the basic difference between this? So absorption time means for how much time the suture is actually physically present in our body. Okay, so those sutures who are absorbable sutures, they have something which is called as an absorption time. What do you understand by the absorption time? How much time is it taking for the suture to get absorbed from our body? Okay, and then there is something which is called as a tensile strength. What do you mean by tensile strength? It means that for how much time the suture is actually effective, for how much time the suture is able to maintain or able to do the work what it is supposed to do, that is approximate the tissues with each other. So both are the different things. Now it doesn't happen that one fine day enzyme comes or maybe the hydrolysis happens and one fine day in a fraction of second the suture is gone away. That doesn't happen. What happens? There is a suture material, on that the hydrolysis and whatever the enzymes are being acted for a prolonged period of time, and over a period of time it reduces its tensile strength, and one fine day it disappears. So if at all the tensile strength is less than 50%, then you call that the suture is ineffective. So absorption time of vicryl suture is in fact 90 days. Okay, so 90 days is the absorption time. But what about the tensile strength? The tensile strength of the suture is around 21 days to 28 days. Okay, so it is basically 3 to 4 weeks. Okay, now different, it varies from place to place. Some places it is given 2 to 3 weeks, but your Bailey says it is around 3 to 4 weeks, so just keep it as 21 to 28 days. I hope you understood the basic difference between absorption time and tensile strength, and this holds true for any absorbable suture. Okay, I hope you understood this. Okay, right, let's move on to the next question. A child comes to you at day 1 of life with a drooling of saliva. So this is a buzzword, and this image has been shown to you. What is the diagnosis of this particular patient? Can you tell me, guys, what is the diagnosis of this particular patient? So a child, day 1 of life, coming to you with a drooling of saliva, and this particular image has been shown to you. Is it a duodenal atresia, tracheoesophageal fistula, ileal atresia, or a choanal atresia? So what is the answer, guys? So Ajmal is saying it's B. Okay, well, yes, the answer is in fact B. Good. So answer is B, tracheoesophageal fistula, no doubt about it. Okay, so again a very simple kind of thing, but yes, it is something which you should remember. So drooling of saliva, what you can appreciate here is there is a coiling of the Ryle's tube over here in the cervical portion. Okay, so it is not, yeah, it is basically the Ryle's tube which you have put up, and this is basically coiling in the upper part of the esophagus. Okay, now can you tell me which is the most common type of tracheoesophageal fistula? Most common type. So the most common type of tracheoesophageal fistula, can you tell me what is the most common type? Type A, B, C, or D? So it is basically type C. What happens in this? What happens in this? Yes, very good, Karishma, very good. So what is the most common type? It is in fact type C. What happens in this? There is an atretic portion of the upper part of the esophagus, and the lower part of the esophagus is communicating with the trachea. So this is the most common type of tracheoesophageal fistula. Okay, so yeah. So this is the most common type, type C. Okay, good. Right. So let us move on to the next question. Good, guys. Good, Ekta. Right. Now, what is the most likely diagnosis of this particular patient? So what is the most likely diagnosis? Is it a squamous cell carcinoma, basal cell carcinoma, melanoma, or nothing? Okay, none of the above. What is the answer? Very simple question. Please answer it fast. So what is the most likely diagnosis of this particular patient? No other information is given, just the image is given. I'm waiting for your answers, guys. So Buck Danish, what is the answer? Okay, so Danish is saying squamous cell carcinoma. Ekta, Karishma, what do you say? So Shraddha is saying B, Ekta is saying A, Karishma is saying A. Okay, C. Understand, Shraddha, it is not basal cell carcinoma. It is not a basal cell. Oh no, Shrikar, it is not B. It is a squamous cell carcinoma. Now, how do you distinguish between these? Okay, so understand one thing. If at all they want you to show an image of a basal cell carcinoma, they will not show you the rodent ulcer. They will not. What they will show you? They will show you a nodular lesion with a central dilated vessel over it, a telangiectatic vessel over it. Okay, so Japinesh, no, it is not that. Okay, I hope I spelled it correctly, but yes, that is not the answer. Well, guys, the answer to this is squamous cell carcinoma, right? And anyways, what is the most common site of basal cell carcinoma? Is it the lower lip or the upper lip? So what is the most common site of basal cell carcinoma? It arises in the, it is also called as a teardrop cancer, right? So it arises from this, above the line joining the outer canthor of the lips to the tragus of the ears. Okay, so it occurs above this. Now this is a typical characteristic squamous cell carcinoma occurring on the lower lip, which is the most common site of squamous cell carcinoma. Yes, so yes, that is the answer. And if at all they want you to show the image of basal cell carcinoma, what they will show you? They will show you nodular or a pearly lesion with a characteristic telangiectatic vessel over it. Now this is again an important image. I don't have it at present, but yes, that is again an important image. Okay, right. Now let us move on to the next question. A patient presents to you with a severe chest pain radiating to the retrosternal region. What is the diagnosis of this particular patient? So severe chest pain radiating to the retrosternal region. Is it an abdominal aortic aneurysm, ascending aortic aneurysm, dissecting aortic aneurysm, or an aortic rupture? Okay, so what is the answer to this particular question, guys? Shrikar, Danish, Jyoti, what is the answer? Right, I'm waiting for you guys. So Danish is saying it is B, ascending aortic aneurysm. Okay, anybody else? Is Danish right? Shrikar, Jyoti, Shraddha, what is the answer? So Karishma is saying again B. Karishma, okay, right. Shraddha is again saying B. Ajmal is saying C. So guys, Ajmal is right or you guys are right? So well, Ajmal, yes, very good. You are absolutely correct. It is a dissecting aortic aneurysm, guys. Okay, so please understand it is not B. No, Ekta, it is not B. Right? No, Ajmal, you're right. Don't be sorry. Okay, you are absolutely correct. The answer is in fact dissecting aortic aneurysm. Now, why is it a dissecting aortic aneurysm? Even if you no, Ajmal, it is not an abdominal aortic aneurysm. No, not at all. Okay, it is a dissecting aortic aneurysm. Right. I'll just explain it to you guys. So see, understand. Even if you don't read this image, even this history is a very, very characteristic of dissecting aortic aneurysm. Now, what happens here? Here, what the question is saying, the patient is having a severe chest pain. So, patient is having a chest pain. No doubt, he will never have an abdominal aortic aneurysm, right? Right. Then, what else? Severe chest pain, and which is radiating to the retrosternal region, okay, or radiating to the back. Okay, so the proper word is actually the radiating to the back actually. Okay, so well, yes, it is radiating to the back. Okay, so if this particular scenario is given, severe chest pain radiating to the back, then the answer to this particular question, no doubt, is dissecting aortic aneurysm. Now, if you just look at this particular image, what are you seeing this? So I'll just mark it with the red. So this big circle which I'm drawing is, this is the aorta. Now, what is this particular image? This is a contrast enhanced CT scan. Okay, why it is a CT scan? Because just look at the bones. It is white, right? So it is a CT scan. So it is a contrast enhanced CT scan. Now let us talk about why is it a dissecting aortic aneurysm. So I hope you can appreciate that the diameter of the aorta is increased, right? Now, if at all you just put up a dye in a contrast enhanced CT scan, and if at all this is an aorta, okay, so the dye should be taken up homogeneously, right? So the dye should be taken up in totality inside the aorta. But what you are seeing in here, I'm just trying to draw and depict what you are seeing over here. Okay, so here what is present, there is a black line which is present, which is breaking the dye into two parts. Okay, can you appreciate this? So here what you have a line which is breaking the dye into two parts. I'm just saying this so that you understand what is it. So this is basically the dissecting membrane. Okay, so dye is entering into the false aneurysm also and inside the main aorta also, and in between these two, what is present? This is this black colored membrane which you can see. This is basically the dissecting membrane. Okay, so that is why the answer to this particular question is in fact dissecting aortic aneurysm. Okay, so did you get it, guys? Now as I am telling you this, that this is involving the ascending aorta. So can you tell me whether it is so can you please name all the structures visible here? Yes, definitely. So what is this? The circle which I have drawn, this is basically the ascending aorta. Okay, so this is an ascending aorta. What is this? Okay, so what is this? This particular thing, the back thing, this is a descending aorta. Okay, so that is an ascending aorta, then we have an arch of aorta, and then we have a descending aorta. So this which I have drawn, this is a descending aorta. Okay, right. So why is it a descending aorta, not an IVC or something? Because it is present on the left side. Okay, so I hope you understand, this is the right side, this is the left side, so this is a descending aorta. Okay, right. What is this V colored structure which you are seeing? Right, so this V colored structure, this is the pulmonary artery. So this is the right and the left pulmonary artery. Okay, I hope you understand this. So these are the major structures which are visible over here. Okay, so understood, Danish? Any doubts? Yeah, pulmonary artery, right? I did tell you, right? So it is a pulmonary artery, right? So any other doubt, Danish? Can we move on? Right. So what I'm trying to tell you is, this is a dissecting aortic aneurysm involving the ascending aorta. So can you tell me whether it is DeBakey's type 1 or DeBakey? Okay, so it is what? DeBakey classification, what is it? 1, 2 or 3? Okay, see, understand, here it is the complete information is not given, but here only the ascending aorta is involved. So that is why it is DeBakey's type 2, or it is a Stanford type A classification. Okay, so good, very good, Ekta. Ajmal, no, it is not 1, it is 2, because it is only the ascending aorta is involved, not the ascending plus descending, both are not involved, because you can appreciate that the descending aorta is of a normal diameter. Okay, so it is DeBakey's type 2 or Stanford type A. Okay, so this is the classification system for dissecting aortic aneurysm. Now this is something which you might not have read, or you might have skipped. So let us talk about this. So what is the ideal age of repair of this lesion? So what is the lesion? Very simple, it is a unilateral cleft lip. So what I'm trying to ask you is, what is the ideal age when you will repair the cleft lip? So what is the answer to this particular question, guys? So what is the answer to this particular question? So Ekta is saying it's B, Karishma is saying it is 6 months, 6 months, 6 months, everybody 6 months. Okay, very good, guys, very good. Yes, in fact the answer is 6 months. Okay, now if I would have changed this particular question and I would have given what is the ideal age of repair of bilateral cleft lip. Okay, so ideal age of repair of the bilateral cleft lip, what is the answer? So answer is not in the options. What is the actual answer? If at all, if I would have given a bilateral cleft lip, the actual answer would have been between 4 to 5 months. Okay, between 4 to 5 months. Okay, right. Okay, right. 4 to 5 months. Very good. Very good. Right. Arshad, very good. Right. It's not 10 months. Okay, bilateral is 4 to 5 months. It is not 18 months. It is not 10 months. It is 4 to 5 months. Please understand this. Right. Now, what about cleft palate? Cleft palate. Now understand one thing, whenever you have a cleft palate, you may have a cleft palate of a hard palate or a soft palate, or maybe both, soft plus hard. Okay, so let me ask you, if you have a isolated soft palate, or if you have a soft plus hard palate. Okay, so first tell me, if you have a cleft palate of only the isolated hard palate, what is the answer? Isolated soft palate. When will you correct this? Okay, see, isolated soft palate, it is not 9 months actually, it is not. It is around, again, 4 to 5 months. Okay, so it is again 4 to 5 months. So answer to this particular patient question is, again, it is around 5 months. Okay, but if you have a soft plus hard palate, then when will you correct it? So here you will have to go for a 2-stage repair. So first stage, you will repair the soft palate at around 5 months, and in the second stage, what you will do, you will go for the repair of the hard palate, and that is at around 18 months. Okay, so I hope you understand this. Okay, so isolated soft palate, it is around 5 to 6 months. Soft palate with hard palate, you go for a 2-stage repair. First stage, you repair the soft palate at around 5 months. In the second stage, you repair the hard palate, that is around 18 months. Okay, so this is just a quick revision of this and that. Okay, so once you have done the surgery for the cleft palate, when you will remove the sutures? Remove sutures. So after a cleft lip surgery, when on what day, post-operative day, on post-op day, when will you remove the suture? Which post-operative day will you remove the suture? What is the answer, guys? So Arshad, what is the answer to this particular question? When will you remove the suture? It is around, when will you remove the suture, guys? So it is around third to fifth day. Okay, third to fifth day. Third to fifth day, not seventh day. No, 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 not at all seventh day. Sutures of the face, this is the suture of the face, right? So when will you remove it? It is just asking the same particular question in a twisted fashion. So they have been asking you when will you remove the suture of the day of the mouth. Okay, so yes, here it is around fourth to fifth day. Okay, third to fifth day, whatever, right? So yes, you're right. It is around fifth day. It is not Arshad. Arshad is not seventh day. Okay, it is around third to fifth day. Right. Now let's move on to the next question. So a patient presents with a neck mass with following angiographic finding. What is the diagnosis of this particular patient? Now again, what is the answer to this particular question? Okay, is it cystic hygroma, carotid body tumor, branchial cyst, or a branchial fistula? What is the answer? Okay, very good, Arshad. It is a right on. It is a carotid body tumor, right? Very good, guys. Okay, so yeah, very good. It is a Larry's sign. Very good, guys. Very good. Okay, it is a Larry's sign. Okay, very good. Now, okay, good. Now, what else you will get on the kind of examination finding? On the examination finding, you will get a neck mass which can be moved in the horizontal direction, but it cannot be moved in the vertical direction. Okay, so this is a kind of buzzword which you will get in the kind of your MCQ on the history. So you will have a neck mass which can be moved in the side to side direction, but it cannot be moved in the vertical direction. Okay, so this is what you will get in the clinical history. And when you perform an angiography, what you get? So this is basically the external and the internal carotid artery. Normally they should go side by side, but what is happening between them? There is this particular mass which is happening. So that is why the branches have to splay apart and then they come and join together. So this splaying of the external and the internal carotid artery, this is basically called as this Larry's sign. Okay, so good guys, very good. Right, now let us move on to the next particular question. What name the instrument? So what is this? Is it a dermatome, Humby's knife, Harvey's knife, or a Henderson knife? What is the answer? Again, a pretty simple question for you. What is the answer? What is the answer, guys? B. Okay, right, okay, very good. So it is a Humby's knife. Pretty simple question. What for it is used for? It is used for split thickness skin graft. Okay, so it is used for split thickness skin graft. What is the other name of split thickness graft? What do you call it? You call it as a Thiarge graft. Okay, you call it as a Thiarge graft. Okay, so you call it as a Thiarge graft. And what is the other name for the full thickness skin graft? Okay, so can you tell me, this is about the split thickness skin graft, that is fine. What instrument do you use to take a graft in a full thickness graft? In the full thickness graft, what instrument do you take? In the full thickness graft? That is very good. It is called as a Wolf graft. Very good. But what? How do you take up a full Wolf graft or a full thickness graft? It is with the help of a not very kind of MCQ point, but just to remember, you take it with the help of a scissor or scalpel. Okay, you cannot take it. Okay, no, not microtome. No, not microtome. It is not dermatome. Dermatome is also used to take only for the split thickness graft only. Here you use your scissors or a knife. What you do is you put in an incision, you reach to a point where there is a junction of the dermis to the underlying subcutaneous tissue, and then you just provide some traction and you keep on cutting the subcutaneous tissue from the dermis. Okay, so you use knife or a scissor, a very sharp scissor, in order to do this. Okay, so right. So this is about the Humby's knife and everything. So this is the split thickness graft. Very good. What is the other name? It is a Thiarge graft. Full thickness graft. What is the other name? It is called the Wolf graft. Very good. Right. So let's move on to the next question. What type of a choledochal cyst has been shown in this particular figure? Okay. So what kind of choledochal cyst has been shown in this particular figure? It is type 1, type 2, type 3, or like it is type A, B, C, or D. What is the answer, guys? Okay. So what is the answer? So really happy to have all of you with us joined today. So very good. It is a Caroli's disease or a type 5, or should right on. Okay, so it is a Caroli's disease or a type 5. What is the sign known as? It is called as a central dot sign. Okay, so what do you get? You get a central dot sign. Where do you get this? You get it in a Caroli's disease. Okay, Caroli's disease. Now, if I ask you, what is the treatment of choice for Caroli's disease? So, what is the treatment of choice for Caroli's disease? What is the answer, guys? Yeah, very good, Arshad. What is the treatment of choice? Okay, so the treatment of choice is in fact liver transplantation. Okay, so it is liver transplantation. Okay, right. And what else? Okay, why are we so much concerned about the choledochal cyst? Because there is a risk of malignancy. Okay, so because this is a risk factor for cholangiocarcinoma. Cholangiocarcinoma. That is why we have to treat every patient of a choledochal cyst. So type 1, type 2, we go for resection, we go for a choledochal jejunostomy. In type 3, what is a type 3 choledochal cyst? Can you tell me, guys? What is a type 3 choledochal cyst? It is choledococele. Okay, so it is basically dilation at the junction of that particular thing into the kind of intestine. So that is a choledococele. How do you treat it? You have to go for a ERCP guided sphincterotomy. Okay, so yes, choledococele, you go treat it with the help of a ERCP. That is fine. Okay, right. So this is about the choledochal cyst, and which is the most common type overall? So the most common type is type 1. So this is the most common type of choledochal cyst, right? It is not de-roofing. You don't go for a de-roofing of that. What you go for is you go via the ERCP route. You go for just the cutting of the wall of that particular cyst. That's it. Okay, you can go for it ERCP guided sphincterotomy or something like that. Okay, so this is about the choledochal cyst. Now, this is something which is again an important and a prospective question may be asked to you. So, what is this instrument used for? Is it used for GERD, achalasia, Barrett's, or the Zenker's diverticulum? What is the answer, guys? So, where will you use this particular instrument? Where will you use this? Any guesses? GERD, achalasia, Barrett's, or Zenker's diverticulum? So Arshad, what do you think? What is the answer? Karishma, Shrikar, Shraddha, what is the answer? So Yogesh is up with the answer. He's saying achalasia cardia. Okay. Ikta is again saying B. Arshad is saying it's D. Danish is saying it's B. Okay. Well, guys. Okay. Now I change the question. Okay, I change the question. I just ask you Linux. Linux is the treatment for what? Linux. I change the question. Linux is the treatment for what? The options are the same. What is Linux? Okay. So now Shalini is answering that it is Linux is the treatment for GERD. So well, this is what is Linux. Okay. So what is a Linux? This is the magnetic beads which are tied together. So these are the magnetic beads which are tied together. So what happens? These are attached with the kind of a string or something. So what happens whenever the food comes, these magnetic beads, they go around and the food goes inside the stomach, and these magnetic beads, they come together. Okay, so this is what is an instrument of Linux. Okay, so please understand, this is a prospective question. It might be asked to you, right? So Linux is the treatment for GERD. Okay, and what is the poem? What is the full form of poem? Where do you use this? So poem is the treatment for? It is a treatment for? This is a treatment for achalasia. What does it stand for? It stands for peroral endoscopic myectomy. Okay, so peroral endoscopic myectomy. This is the treatment for achalasia cardia. But here the answer is GERD. Okay, so please understand this. This was already asked a couple of years back. So this can be asked. Okay, so Linux can be asked. Okay, right. Very good, Shalini. Very good. Right. Now let us move on to the next question. How much air? So first MCQ is in fact what is injected. So we inject air. We don't inject fluid inside it. Okay, so how much amount of air is injected in the gastric balloon? What is the answer to this particular question? What is the answer to this particular question? Is it 100 ml, 200 ml, 300 ml, or 400 ml? So the question is asking, so what is this basically? This is a zinc stick in Blackmore tube, and what they're trying to ask you is how much amount of air will be injected in this. So all of you are answering. Ekta is answering A. Okay, Shalini is answering D. Okay, Danish is again answering A. What is the answer to this, guys? Okay, Shraddha is A. Okay, well, Shalini, yes, you are again correct. What is the answer to this particular question? 400 ml. Okay, so around 400 ml of. I'm really sorry. That is not the answer, Shalini. I'm really sorry. You're wrong. The answer to this particular question is C. The answer to this particular question is 300 ml. Okay, so how much amount of total air is injected into the gastric balloon? It is 300 ml. Okay, right. I'll explain to you what happens. Okay, so you all know what is the indication of zinc stick in Blackmore tube. It is to control the bleeding from the esophageal varices. Okay, so how do you do it? You put in this tube and you inflate the gastric balloon. You first inflate around 50 ml of air inside the gastric balloon, and then you pull the gastric balloon up. So when you pull the gastric balloon up, what happens? It gets stuck in the lower part of the esophagus, and then later on you inject more 250 ml of air. So ultimately the total comes out to be 300 ml. So why you have to put this much amount of air? Because you want to create a tamponade effect and you want to control the bleeding. So this is the particular thing. Okay, so 50 ml of fluid air first and then 250 ml of air. Okay, so did you understand this? So this is basically the zinc stick in Blackmore tube, and ultimately you go for 300 ml of air. So Shalini, please note, it is not 400. 400 to 700, that is used in the Linton's tube. Linton's tube is the tube which is having only one balloon. Okay, so that is used in the Linton's tube. Okay, so this particular, the answer is in fact 300 ml. Okay, right. So let us move on to the next question. What is the diagnosis of this particular patient? Okay, so what is the diagnosis of this particular patient? Okay, so what is the diagnosis of this particular patient? Can you tell me? Is it A, B, C, or D? It is a leukoplakia. Is it BXO? Is it paraphimosis, or it is a coronal papillae? Now, again, an important MCQ might be shown to you. What is the answer? A very simple thing, but yes, you need to have a note of this. So, paraphimosis, really? Okay, Arshad is saying D. Really? Coronary papillae? Okay, Shalini is saying C. Okay, finally Yogesh has answered it as B. Yes, you are absolutely correct, Yogesh. The answer to this particular question is in fact B. What is BXO? It is balanitis xerotica obliterans. Okay, so it is balanitis xerotica obliterans. Okay, so this is the image of that. Okay, so what is balanitis xerotica obliterans? It is a predisposing factor for phimosis. Okay, it is not a predisposing factor for paraphimosis. It is a predisposing factor for phimosis. Okay, so you can see here there is a pinpoint urethral opening. It cannot go back. So this is basically a phimosis, not a paraphimosis. Okay, first thing. And what is the cause of this? The cause of this is BXO. Okay, so this is a characteristic finding. What does BXO does? BXO basically kind of causes a stricture kind of a thing over a scarring of the skin over the distal part, and patient is not able to retract the thing back. Another important point about BXO is, yes, it can involve the urethra also, and that is why it can predispose to the urethral strictures. Okay, so it can involve the urethra also, and it can predispose to urethral stricture. Now, coronal papilla, this is an important image again. This was asked in the recent MCI exam. As the exam conducting body is the same, you might get an image of this. So what is a coronary papilla? You will find a proper glans and whatever, and you will find pearly papules all around. So this is what is a coronary papilla, but this is not a coronary papilla. Okay, so I don't have an image of that. I'm really sorry for that. But yes, coronary papilla, the image was asked in the recent MCI exam. Exam governing body is the same, might be asked. So that is why I put up this BXO. Okay, so I hope you understood this. Right now, this is also a risk factor for carcinoma penis. Okay, so that is why if at all the patient comes to you with BXO, you have to go for a circumcision and have to send this particular skin sample for the histopathological examination to rule out if at all carcinoma has already developed or not. Okay, so this is about the BXO. Now, coming to the last question of today. Now, I assume that everybody should get this particular question right. Okay, right. A patient presents with the bilious vomiting at day 1 of life. X-ray of the patient has been shown to you. What is the diagnosis? So what is being shown in the X-ray? This is a double bubble appearance. Okay, so it is a duodenal atresia, annular pancreas, ileal atresia, or a midgut volvulus. What is the answer to this particular question? Okay, so you don't get double bubble appearance in annular pancreas. A double bubble sign, that is fine, but don't you get it in annular pancreas? Okay, right. Now, it is actually my mistake. I didn't frame this particular question in a very, very smart manner. Here, I should have given you non-bilious vomiting. Okay, I changed this question to non-bilious vomiting. What is the answer now? A patient is coming to you. Okay, so if I change it to the non-bilious vomiting, what is the answer? What is the answer to this particular question? Now this is the particular question. Okay, a patient coming to you. Arey, don't write yes. Just tell me the answer. What is the answer to this particular question? The patient is saying having a patient with a non-bilious vomiting on day 1 of life. and this is being shown to you. Very good, Arshad. Now you have got it. So please understand, if you have a double bubble appearance, okay, so you all know this. Very good, guys. Okay, so if you have a double bubble appearance and if you have a bilious vomiting, then the answer is duodenal. But if you have a non-bilious vomiting, then the answer is annular pancreas. Okay, so please understand this. This is a very basic difference, but this question has been asked repeatedly in your NEET exam. So again, I'm repeating, double bubble appearance with bilious vomiting, answer is duodenal atresia. Double bubble appearance with non-bilious vomiting, answer is annular pancreas. Okay, so I hope you understood this. Okay, so this was about our last MCQ. I hope you found this particular session useful. Just give me a couple of minutes. I want to share a couple of thoughts with you. So I hope you like this particular session. And if you liked it, please follow me on Unacademy. My link is given on the description box below. So you can just go on my page and you can like that. Okay. So please follow me. You will get the updates of my free special classes which I conduct on the Unacademy platform and all these things. So thank you so much for joining me today, just 40 days before your exam. So I just want to talk to you about your exams. Okay. So your exams are around 40 days ahead, right? And I assume that it is a stressful condition. Yes, it is a stressful condition. But what I want from you is, I don't want you to get backed down by the pressure of the exam. Okay, so don't let the pressure of exam back you down. What I have observed is that around 80% of the students, what they do is, they either stop reading or they reduce their reading drastically under this pressure. Okay, so this is what I've observed over a period of years. So I just assume one thing, I just want that this should not happen to you. Now, what is to fear of? So you guys, like some of you guys must be having a fear of exam. What will happen after the exam? Okay, so don't fear about this. The worst thing which can happen is, if you have studied something and if you're not able to deliver it in the exam. So this is the worst thing which might happen. So this will happen if you get under the pressure of the exam and you reduce your reading, or you get, stop your reading. So this is something very, very worse. This should not happen. I understand it is very easy said and done, but this is something which you have to conquer, okay, in order to succeed in the exam, because exam is not just a test of your knowledge, it is also a test of your mental stability. So I just tell you that every one of you is in the same boat. Don't panic. You guys have read enough. I could see by the amount of answering which you have done, you guys are well prepared. Just keep your calm and just go for the exam. Around 80% of the questions will be from the normal, simple, repeated topics. Okay, not the repeated topics, the most important topic. And you can answer them properly if you keep your cool. And what I want from you, in the coming 40 days, you have to revise those 80% of the topics. Okay, right. And I'll just spend a couple of minutes telling you what are we doing on our plus subscription, and you can decide for yourself. If at all you feel that it might help you, you might come and join it. If you don't, it's completely fine. I completely understand. The major crunch is the time. So I'll just spend a couple of minutes. Just stay with me. We started with our medical marathon on 15th of November. It is about to get complete on 15th of December. What is happening in this? Each and every educator will come and he will kind of discuss his particular subject in a comprehensive manner. I took around 10 hours of general surgery there, and then there are 4 hours of MCQ discussion also between 11 to 15, right? That is fine. So this is about medical marathon. Myself, I have launched a particular course that is a revision course in general surgery. Now, if you are someone who has already read general surgery very nicely and revised it a couple of times, this might not benefit you. But if you are someone who is struggling a bit with the revision in general surgery, you can come and attend this session. What is there? There are 20 sessions of 2 hours each. I have divided the sessions into, let's say, hepatobiliary 3 sessions, GIT 5 sessions, general surgery 6 sessions, urology 3 sessions. And there is a very special session, one session on all the important classification systems anywhere in the general surgery. Then there are 2 sessions which are dedicated to the image-based questions. And there is one session which is dedicated to all the eponyms, let's say the triangles and the named surgeries or the triads or all those things. So this is what I'm doing in this particular revision course. If you wish to join, you're most welcome to join. You can use my promo code. At this moment, we are offering the unlimited access to any video by any educator on this particular platform, along with all the videos of the medical marathon at 999 rupees. If you use this promo code Dr.Pawan, and this particular offer, this ends on 30th of November. So this is the last date. Okay, so we know that you don't have time. But if at all you want to use it strategically, let's say you have a problem in pancreas, let's say you have a problem in some particular topic in different subjects, you can just come and attend that particular thing only. So timings clash with other class, OBGYN surgery at the same time, 10 a.m. I understand, Danish, but what can we do? I mean, it is kind of a bit difficult. See, understand, at this moment, you guys are comparatively free, but let's say the next batch will come, it will become, let's say, interns. We cannot keep the batches between 12 to 5 p.m. or something like that. So, yeah, I mean, we are trying to working on it that the classes should not clash. From the January session, we will work on it, but at this moment, I'm really sorry. Yes, I understand that is a problem. Okay, so right. So thank you so much for joining with me. You join or you don't join, that's completely fine, guys. But please stay focused. Please be calm. Please go for the exam bang on. And if at all you want to use our platform as a way of your strategy and revising, you can use it. You can use this code. Offer is 9.99 till 30th November. You get unlimited access to everything, and this is a special revision course which is specially devised for the patients, students who are having trouble revising general surgery. So thank you so much. This was Pawan, and yeah, follow me on Unacademy, and thank you so much. All the best. Happy reading. Okay, so see you guys. Bye.